Medurstand. Understanding medicine.
This is Professor Aziz Rehman from channel Medurstand, and if you have not subscribed to my channel yet, please do consider it now. Today we're going to talk about this topic called dysphagia, and this is actually not a disease in itself. It's a symptom which could reflect many diseases. It could be a symptom of a neurological disorder, or it could be a symptom of a mechanical disorder, or it could be a symptom of a psychological disorder. So we will be defining dysphagia and going through its differential diagnosis, and also some investigation and some brief treatment points. Of course, depending upon individual condition, the treatment plan would vary. So I will be just definition, simply speaking, it is difficulty to swallow. Normally we have a very delicate swallowing mechanism. Without any difficulty we swallow things, but it's not just passive pouring food into the stomach. And in the next slide I'll explain to you the exact mechanism, and only then we can understand various causes of dysphagia. So if somebody has the desire to eat food, can chew also, but he has difficulty swallowing it because the mechanism which is required for swallowing is defective, then this condition is called dysphagia. There are some similar symptoms which can be confused with dysphagia, but precisely dysphagia is difficulty to swallow food, either liquids or solids or both. Now this picture will explain to you, which should be, I think, otherwise also obvious, but just for the sake of completion, let's discuss how this swallowing mechanism works. There is of course a center in the brain which regulates our swallowing, and in the first phase, this green is the bolus, is the preparatory phase. Most foods are not ready to swallow before we chew it. So in a variable period of time we chew it in the oral cavity. Once it is ready to swallow, and at this time the patient can be breathing. Of course, breathing through mouth is not easy. A patient is breathing through the nose, and this cavity and this trachea is in alignment. So patient is breathing as well as chewing. In the next stage, when we actually push the food backward with the help of tongue muscles, you can see the tongue has changed its configuration because tongue muscles have contracted. They have pushed the food backward, and at the same time palate has risen and palate has closed nasopharynx, and the trachea is also covered. Trachea moves forward and upward. In that process it is covered by the epiglottis, and the pharynx opens up. The upper esophageal sphincter opens up and food goes into the esophagus, the upper pharynx and then the esophagus. And this part is actually mostly neurologically driven through the brainstem, and these are the skeletal muscles, the striatal muscles. But then once it goes into the upper part of the esophagus, then the rest of the esophagus is simple smooth muscles, and distension of esophagus due to bolus that initiates a peristaltic wave that pushes food contents into the esophagus to the lower end. And in anticipation of food coming, the lower esophageal sphincter relaxes so that peristaltic waves in the esophagus effectively move the food into the lower part and then into the stomach. Now, if this synchronization does not occur, there could be a problem. For example, if there is a problem here, patient is likely to choke, patient is likely to have coughing, patient is likely to have regurgitation. If there is a neurological mechanism and the palate doesn't rise and this nasopharynx doesn't close, or the trachea doesn't move forward, or food is not properly pushed into the esophagus, all these can lead to regurgitation and dribbling and choking and coughing during meal, and this is mostly neurological. Once food is in the esophagus, it could get stuck somewhere because of a tumor, because of a stricture, because of narrowing of esophagus from outside, and one condition called achalasia, and we will be talking about it in the lower part of the esophagus, where esophagus, the lower part, the lower sphincter does not open up because of a neurological problem. So one or more of these conditions can cause dysphagia. In some diseases, it may be just one factor, like for example, in esophageal stricture, it is only mechanical obstruction. But in some cases, there may be multiple factors, like in systemic sclerosis, there is scarring of esophagus and there is also problem with the neurons. So that could be a dual problem. And in achalasia, there is a neurological problem. Again, there is problem with the peristalsis. So this was a brief account of normal swallowing mechanism and how any problem can lead to dysphagia. Broadly, dysphagia can be classified into three categories. One is neurological, the other one is mechanical, the third one is psychological. Psychological, we will not deal in more detail, we will not discuss in more detail, but I think a detailed interview can clearly demonstrate that this is psychological. Psychological is basically unwillingness to swallow, and you can tell that patient is trying to pretend that he or she is not able to swallow. There is no neurological mechanical problem. So our main differential diagnosis would be on neurological versus mechanical. And detailed history and detailed physical examination and some tests would tell you if it is neurological or mechanical. So of course it is important because symptom is the same, but the treatment plan would be different. In neurological, since there is a neurological circuit involved, so any problem with the brain stem, medulla oblongata, any problem called bulbar palsy or Parkinson disease or dementia, because dementia affects all upper brain functions including cognition, recognition and other things, and stroke, post-stroke, especially somebody has suffered from multiple strokes. So any advanced neurological disease can cause dysphagia. Now coma would be an extreme example, but somebody who is comatose, we don't expect him to swallow, so of course that is not included here. So I think any of the advanced neurological disease, many of them are not listed here, they can cause dysphagia. And in mechanical, we have peptic stricture. Peptic stricture means because of chronic acid peptic disease or regurgitation of acid into the stomach, the intestine has shrunken and there is a stricture formation. This would be very, very gradual onset, and patient would have history of dyspepsia and there would be history of reflux also in many cases. Tumor, especially in elderly, this would also be relatively slow in growth and there could be additional symptoms suggestive of malignancy like hoarseness of voice, there could be weight loss, and there could be some physical finding. Achalasia is a very interesting condition. I will have one or two slides on this condition. Achalasia, there could be again very, very slow onset and progressive disease. In this, the lower part of the esophagus does not dilate and food accumulates in the esophagus, and esophagus dilate and patient experiences dysphagia. Schatzky ring is again a ring which is at the lower end of the esophagus. This is supposed to be the commonest cause of dysphagia. There is actually narrowing of the junction of lower end of the esophagus and the lower esophageal sphincter. So where there is gastric and esophageal mucosa joining, at that level there is a stricture. All these conditions, they develop slowly. There could be another cause of dysphagia, like somebody has ingested some foreign body. A food bolus has impacted into the esophagus. That may cause acute dysphagia, but most these conditions, they would cause very, very slow symptoms, and there may be a situation when patient has the problem but does not have the symptom. So even if somebody has subtle symptoms, I think we need to listen to the patient carefully, because that might lead to an early diagnosis, and of course early diagnosis means early treatment and better outcome. So how do we evaluate? First of all, history. We need to ask the patient what exactly is the problem, and is this swallowing difficult because patient has pain, that would be called odynophagia, or is the solid more difficult to swallow or liquids more difficult to swallow, or is this intermittent or continuous, how long dysphagia has been. And I think this all, and plus is there any choking or coughing when you swallow, or is there any history of recurrent chest infections. All these points will lead us to the diagnosis. In physical examination, we'll see the general condition of the patient, if there is any wasting. And I think one particular thing is examination for lymph nodes in the supraclavicular foci. Gastro-intestinal malignancies, especially stomach and esophagus, they can cause metastasis in supraclavicular nodes, and that lymph node, if it is enlarged, can provide you the clue. Then, of course, physical examination of the GIT, sometimes you can feel the mass in the stomach. So physically, and if you suspect neurological cause, then of course examination of the cranial nerves. You would ask the patient to open the mouth and see the palate movement. You will ask the patient to say ah, and if the palate does not rise normally, if one side doesn't rise, or if there is asymmetry in the pharyngeal movement, the tongue movement, that would also lead to the diagnosis of neurological. Then imaging. Imaging plays an extremely important role. Imaging could be barium swallow, or it could be some other kind of imaging, and I will be talking about that in some more detail later. Imaging used to be the investigation of choice because we did not have better investigation, but now it has been replaced by upper GE endoscopy. Imaging is still valid. In many cases, imaging is still useful, and it complements the information we get from upper GE endoscopy. Some conventional gastroenterologists and physicians, they still feel that we should do imaging first and then move on to endoscopy. But I think perhaps endoscopy has got better things to offer, so that may be done first of all, but both are usually required. So endoscopy, I have already explained. Fiber optic endoscopy is direct visualization. It will tell you if it is stricture or a tumor, where exactly. If there is a tumor, it would provide the opportunity to take biopsy, and if it is achalasia, it will provide you the opportunity of doing further tests, and of course in a separate setting, maybe manometry, maybe dilatation. And I think endoscopy is definitely better. And remember, in some neurological problem, endoscopy may be absolutely normal, and you could just see the esophagus is absolutely normal mucosa, no obstruction, but there is dysphagia. So that is why I say imaging and endoscopy both are required. Then other, as you suspect, esophageal manometry or pH monitoring, a CT scan, MRI, they may all be needed. In history, so I briefly explained, but exact nature of problem and solid versus liquid, dribbling, regurgitation or gagging, etc. during swallowing, level of obstruction. Patient can sometimes pinpoint the exact level where it gets stuck, but there is a lot of false localization. Patient may feel that it gets stuck here, but actually the problem may be in the lower esophagus. So we still have to do endoscopy to find out the exact problem. Unaltered food in the vomitus. This is very crucial information. If somebody says he vomits out food contents what he ate 24 hours earlier, and the foods are so undigested. You can tell, actually, you can identify the food. There may be little bit of fermentation, but no digestion. This is very strong suggestion of achalasia. That means the food actually never went into the stomach and digestion did not start. So that is why undigested food is vomited out in 24 hours or later. So this would be highly suggestive of achalasia. Foul smelling, again in achalasia, if the food stays there for a long time, for hours and days, there could be fermentation, superadded bacterial infection that could lead to foul smell, and wasting. Wasting, of course, anybody who is not able to eat food properly would lead to wasting, but it would particularly suggest a malignant process. In physical examination, you examine the pharynx and palate. You ask the patient to open the mouth. With the torch, you see if anatomy of pharynx and palate is intact. And then, of course, you will ask the patient to say ah, and in a normal person, palate should rise in both sides and the medium raphe should remain in the medium. So if one side does not rise, the other side pulls the raphe to that side, that would be a sign of one-sided paralysis. Then cranial nerves, 5th, 7th, 9th, 10th, 12th, these are the nerves which regulate our swelling. I will not go into the details, but we have to conduct a neurological examination to rule out any problem with any of these nerves. Supraclavicular node should be examined, wasting should be looked for. So these are the important points which lead to the right diagnosis. Now I'm going to show you some examples. This is the barium swallow. Barium studies include barium swallow, barium meal studies, and barium follow through, barium enema. This one is barium swallow. As the name says, patient is given barium to swallow, and while patient is swallowing, then you take the image of the esophagus because it would outline the esophagus. In a normal person, this whole esophagus would be outlined uniformly, smoothly, and there will be a narrow column. But depending upon the disease, you can tell what is the problem and what is the level of problem. So stricture, for example, this is the stricture. This is the normal esophagus, and there is a long stricture you can see, and then again there is normal. I think this is perhaps stomach, but there's a long stricture. No corrugation. I don't really suspect malignancy here, although it is difficult to 100% rule out, but it looks like simple benign stricture. Here again you can see even longer. It starts from here and goes down up to the stomach. So long stricture. This could be a fact of acidity or previous radiation, previous surgery. So this is long stricture you can very easily identify. One point in favor of doing barium swallow before we go for endoscopy is to have an idea where exactly is the problem. You know, those who do endoscopy, they know that when we push the scope down the pharynx, there is a brief period when we don't see anything. Because when patient swallows, we push the endoscope inward and we get blinded for some seconds. So if the lesion is in the upper part, we could actually do some injury there. Before we do endoscopy, we need to know where exactly is the problem. So in this patient, we would know that it is somewhere in the middle. And in this part, we know that it is in the upper part before we do the endoscopy. This is another stricture, a slightly smaller one, and this is a very simple, smooth outline, but this you can see the stricture. But please remember, if sometimes you can confuse the normal peristaltic wave with the stricture. So this has to be consistent defect on multiple images. You take images from different sides and it persists, only then you would call it stricture. Peristaltic wave would just be a momentary phenomenon and then disappear. And in some cases, whenever there is stricture, there is hold up. The upper esophagus may be dilated. In this case, I don't see much of dilatation. Massive dilatation would be a feature of achalasia, but mild to moderate dilatation may be seen in benign strictures also. So this is another benign stricture, and the treatment will be planned accordingly. Of course, endoscopy would be needed both for diagnosis purposes as well as for the treatment purposes. Achalasia, I have a detailed slide later, but this is the appearance of achalasia on barium swallow. You have massive dilatation. Just note 3 points. One is massive dilatation of upper esophagus, because achalasia is truly a very chronic condition, and there are two defects. One of them is failure to relax. The lower esophageal sphincter does not relax, and then the rest of the esophagus also does not initiate peristaltic waves very effectively, and food accumulates. So this is barium accumulated in the upper part, and then this fluid air level, because there would be air. So this is another sign. Then this classical tapering, bird's beak pattern, this gradual tapering is another characteristic feature. So this is achalasia. Of course, this is highly suggestive of achalasia, but endoscopy and other tests would be needed to confirm the diagnosis before we plan treatment, which could be medical and in some cases surgical. Malignancy, now this is again looks like stricture, but you can see the shouldering effect. Look at this. This is very typical rough and irregular mass filling defects, and upper esophagus is dilated, and you can see there is definitely a very irregular, you can imagine the solid structure on both sides is impinging upon the esophageal lumen, and it is causing narrowing. And this type of appearance would be suggestive of growth. A normal outline should be like this, a smooth outline, but this part which is actually part of esophagus but not outlined, it is not outlined because it does not have barium in it. Why it doesn't have barium? Because this part is occupied by the tumor. So this is highly suggestive of malignancy. Endoscopy would definitely be needed. So role of upper GI endoscopy, there used to be a rigid endoscopy also, but of course that is not done, but that is not an obsolete. Some esophageal surgery is still done with rigid endoscope, because that provides a more the wider view and a stable view, but that is done only under anesthesia. Upper gastrointestinal endoscopy, fibro-optic, is a simple test and can be done without anesthesia definitely, but maybe without sedation also. It is direct visualization, and you can see that what is exactly inside. So this is the example of esophageal ulcer. You can see this linear ulcer. This is covered by the sloughed mucosa. This you can see this part is ulcerated, and in this case it is ulcerated. I don't see any background growth, so I don't think that I would even suspect malignancy or anything. It is acute ulcer, maybe due to some infection. Some infection can also cause ulcer, maybe acidity, maybe corrosive intake, but this is just simple ulcer. There is no narrowing of esophagus. This is malignancy, you can see, and this is actually the lower part. You can see the endoscope here. It is retroflex. The endoscope is passed into the stomach and then turned by 180 degree, and you are looking at the lower end of the esophagus. This is a big growth protruding into the stomach from the esophagus. So this growth can very definitely easily be diagnosed, this one. So this is most likely adenocarcinoma. You can of course take biopsy. The diagnosis of malignancy will be based on biopsy, but this of course looks very much like a malignant tumor. Biopsy can be done, and you can see, and this is the biopsy. So biopsy will provide you the definitive diagnosis. Adenocarcinoma. Previously, squamous cell carcinoma used to be common condition, maybe due to H. pylori infection or maybe due to some other factors. Now, adenocarcinoma of esophagus is becoming more and more common. There could be tight stricture in the upper endoscopy. You can see this is a very tight pinhole stricture. You can see this is actually esophagus. You see the esophagus and there is a very small pinhole stricture you can see here. Tight stricture. Now you can also see dilated esophagus. This is massively dilated esophagus. No food contents because it has been cleaned for endoscopy, but you can appreciate that the esophagus is dilated with no ulceration or mucosal disease. This would be highly suggestive of achalasia. But achalasia can be missed on endoscopy because mucosa looks very normal, and you can pass the endoscope without difficulty. Although there is narrowing of the lower part of the esophagus, but since it is not stricture, it is not mechanical obstruction. When you push the scope, it passes easily. It does not allow food to go further because it does not relax, and endoscope is a relatively rigid structure, and you push it with a little force, that passes easily. In a structure, that will not be the case. So endoscopy provides great information. So I think I would like to repeat my message. Both are crucial. Imaging of the upper GIT tract and endoscopy, both are crucial. Both provide complementary information, and if you have to choose one, that of course would be endoscopy. Now, endoscopy not only provides a diagnostic option, it also provides treatment options, direct visualization. Esophageal ulcer can be diagnosed, esophageal growth can be diagnosed, and biopsy can be taken if there is a tumor, and tight strictures can be dilated with balloon, and there is also in achalasia, this is a guide wire, and this is actually balloon which is deflated, and this is a guide wire put over there, and then it is dilated, and then you can see the esophagus which was tight here, and it is now dilated. This is the procedure, the basic principle of dilatation of esophagus with endoscopy. There may be a situation when there is dysphagia and both upper GI endoscopy is normal and barium swallow is normal. I emphasize that both provide complementary information. In majority, we should be able to make a definitive diagnosis after barium swallow and upper GI endoscopy, but there may be some cases where both are normal and patient is still saying that he or she has this dysphagia. That could be psychological cases, but we have to do manometry. There may be some functional abnormality with the esophagus. Maybe the entire esophagus contracts, but a typical peristaltic wave is not produced. Though it could result in what is called corkscrew esophagus. Then pH monitoring may also be needed. Sometimes patient may have this reflux which may not be obvious on endoscopy, so pH monitoring will tell you that if there is reflux of acid into the esophagus. Stricture. Now very briefly I'm going to talk about these conditions. What is a stricture? It is due to chronic gastroesophageal reflux disease. Gastroesophageal reflux disease is a disease which typically seen in obese people and those who have hiatus hernia, and the typical symptoms are regurgitation of food into the esophagus and into the mouth. So that is called reflux, and then there is acidity. There is a pain here and followed by dysphagia. So if that is the case, there may be that could cause stricture formation. Caustic ingestion, very unfortunately in our country, people still take these caustic substances. I'm not sure if they take it just to take attention of the family or they want to kill themselves, but mostly patients end up having very, very problematic lifelong ailment and very bad stricture in the esophagus. The treatment of both would be dilatation. Initially, we try to do dilatation with endoscope, but some patients would require surgery. Then adenocarcinoma, rising prevalence, What is the cause? Maybe increasing prevalence of GERD. GERD is increasing in prevalence because we now overeat. That is one factor. We are now overweight. That is another factor. And we mostly go to sleep without doing physical activity. That is third factor. So since these factors are more common, GERD is increasing in its prevalence. That is perhaps also increasing the incidence of adenocarcinoma, or maybe H. pylori. H. pylori is also becoming more and more common. There may be signs of malignancy. Typical signs of malignancy are weight loss, or maybe spitting of blood from mouth, and lymph node palpable or localized pain. These are the things which would suggest presence of malignancy, and the prognosis would be poor. Why? Because many times the tumor would have already gone beyond esophagus. Outside esophagus, we have very vital structures: the mediastinum, the heart, the trachea, and the aorta, and the other structures. So once it is outside the esophagus, it immediately affects other organs, and patient will not be then fit for any kind of surgery, at least curative surgery. So I think that is why the prognosis of adenocarcinoma of esophagus is very poor. If somebody is diagnosed early, then treatment could be, surgery may save his life. Now, achalasia, I told you I will talk about achalasia in some more detail here. There is degeneration of myenteric neurons. What are those myenteric neurons? There is a mesh of neurons and plexus under the mucosa which regulate our muscle contraction. When we swallow, these neurons, they initiate peristaltic wave in the, first of all, they open up the upper esophageal sphincter, then they initiate a peristaltic wave in the esophagus, and once food is here, they, in anticipation of food coming, they relax these muscles. And if there is defective, then this mechanism will not occur. There may be, these neurons are cholinergic, which is stimulatory, which initiate this contraction, and nitric oxide, which are dilatory or inhibitory, which are responsible for dilatation of the lower end of the esophagus. So this mechanism is not there because there is progressive degeneration of both type of neurons. So in achalasia, we actually have dual problem. We have main problem is inability of the lower esophageal sphincter to relax, but an equally important is inability of these muscles to produce an effective peristalsis. So this is what causes achalasia. And this picture, you see that this is tight and this is open, this is tight, and progressively esophagus dilates as compared to this one. Lower esophageal sphincter does not relax and there is ineffective peristalsis also. Esophagus dilates. Barium meal gives a characteristic picture. I told you dilatation of esophagus with fluid air level and a bird beak appearance in the lower end, and endoscopic pneumatic balloon dilatation is the treatment. And this picture they also show endoscope is passed, and through that another device is passed which has a balloon, and that balloon is deployed here, then inflated, and it will dilate. And it would have a variable result. Typically, patient would have to have this procedure repeatedly. After one dilatation, patient would have symptom-free period, 6 months, 1 year, another dilatation, another dilatation. Typically, patient have to have multiple dilatation. In some patient, we have to do surgery. I think there is a procedure where this is a laparoscopic procedure where these muscles are cut, myotomy. So that procedure can be done in those patients who do not respond to. Hiatus hernia is another similar condition. In this, there is actually part of stomach is in the chest. Normally, lower esophageal sphincter is supported by diaphragmatic sphincter. So if there is problem, if there is for example, esophagus is small, it would cause sliding type of hiatus hernia. So some part of the stomach is already above the diaphragm. So that acid will regurgitate into the esophagus anytime. But in normal person that does not happen, because whatever factor promotes regurgitation, for example, if we cough, we sneeze, or we strain, that would raise abdominal pressure, that might push food upside into the esophagus. But at the same time, there is contraction of diaphragm, and that would actually reinforce the contraction of lower esophageal sphincter and would not allow food to regurgitate back. This is the normal mechanism. In normal healthy person, even if lies flat or even bend or even goes upside down, there is no regurgitation of food because of lower esophageal sphincter supported by diaphragmatic muscle. But if these do not coincide and if there is dilatation of hiatus, then this could result in hernia, sliding hernia or parallel hernia. This would cause GERD, and this may cause dyspepsia, this may cause stricture. Now, other endoscopic disorders, which I will not be able to cover in detail, but very briefly, a condition eosinophilic esophagitis is becoming common. It is perhaps some kind of allergic disorder, but characteristic is typical rings, multiple rings are formed and there is inflammation, and biopsy will be diagnostic. Divertically, there could be congenital divertically, there could be acquired divertically, and they could cause dysphagia. Plummer-Vinson syndrome, typically an association of chronic iron deficiency, that would cause also dysphagia. Pale esophagitis, if you take medicine with small amount of water and you do not, or you just take small sip of water and then lie flat, then pill could get stuck in the esophagus and could cause ulceration, and patient would develop odynophagia. The commonest pills I have seen is this tetracycline, vibramycin, but theoretically many other drugs like bisphosphonate, they are non-steroidal anti-inflammatory drugs, they can cause esophagitis. Radiation esophagitis, if somebody undergoes radiation for breast cancer, for lung cancer, for metastatic cancer, and that could also cause radiation esophagitis. Then infective esophagitis. Candida, I have seen fairly commonly. Candida occurs typically in those patients who have immunodeficiency state, patient with HIV infection. They can have superadded Candida albicans. Those patients who are debilitated, they do not properly eat, they're old, they can also develop esophageal infection with Candida. And there could be herpes simplex esophagitis, a syncytial virus infection. So multiple viruses can cause esophagitis. Bacteria are not very likely to cause esophagitis, at least not enough to cause dysphagia or stricture. So this was a brief account of dysphagia. Again, dysphagia is a symptom, not exactly a disease, with multiple etiologies. So an initial evaluation based on history, physical examination, barium swallow, and endoscopy is essential. That will give you the right diagnosis, and only then you will be able to offer right treatment. Either you will treat the patient medically, or you will refer the case to your endoscopy and gastroenterologist colleague or a surgeon for a better treatment. With that, I'd like to thank you for joining Medurstand. If you have not subscribed to my channel, please do it now. Thank you. I will see you in my next video.